Hello, Johannes Keating here. Today I'm going to talk about the perspective and proportionality quadrants. This is something that I recently developed, hoping that it might help with prioritization. How do we know what to prioritize when throughout the course of the psychotherapy treatment? So here's an overview, my ISTDP perspective and proportionality quadrants, or PP quadrants for short. So here, to break it down on this side, so these two quadrants right here, Q1 and Q4, they primarily deal with psychodiagnostic considerations, whereas Q2 and Q3 primarily deal with therapeutic stance considerations. And these two, Q1 and Q2, if we look at this little thing here, we can see that they primarily deal with the conscious mind, whereas the bottom half, Q3 and Q4, primarily deal with the unconscious. Okay, so let me zoom in so I can break this down properly. So quadrant one, this is going to be where it's all about all things related to will, the conscious will. Consensus on problem and task. Is there a robust or tentative buy-in in terms of the therapeutic task? And this is, of course, assessed not just once, but throughout the entire course of treatment, over and over throughout, woven in. Consensus on a formulation of core conflicts, the conscious therapeutic alliance, basically. So that's all Q1, all things related to conscious will. Okay, and again, part of the conscious mind up here, right? I am putting it on the side of psychodiagnostic considerations, but it also could be put in on this side, the therapeutic stance consideration. So the dividing line here between these quadrants, they're not hard and fast. Various items bleed over into other quadrants. But having said that, Q2, all things real relationship, the non-transferential component, as well as the subjective countertransference. So the therapist's own unresolved emotional conflicts, their own anxiety, their own defenses, that comes into play in Q2. Can the patient differentiate the therapist from past figures? Is the therapist establishing themselves as someone the patient would want to open up to? Is there emotional closeness and real contact? Is there the shared dream experience where the therapist can picture in detail what the patient is talking about and vice versa? Here is where we go for corrective emotional experiences. Here's where we rely on use of self. Here's where we might acknowledge mistakes we've made or where we're honest about reactions we're having to the patient. Here is where we try to restructure insecure, avoidant, dismissive attachment patterns. And here is where we also want a consensus on a formulation of the core conflicts. And like I mentioned, this is the subjective countertransference quadrant. Okay, and the consensus on the formulations of the core conflicts, I put that here too in Q1 because they both really overlap. Okay, so we have Q1, we have Q2, and then moving right along, Q3. So now we're still on this side, therapeutic stance considerations, but we're down here, if you look over into the more of the unconscious realm. And so all things related to the transference, including countertransference, but here I'm referring to the objective countertransference, meaning the countertransference we feel is a diagnostic tool that can give us insights into what's going on for the patient. But here it's about allowing the therapist to be a safer object where transferential material can be addressed and worked through. Transference resistance here is seen as a guide to unresolved conflicts in understanding the patient's history. And it's also the key to unlocking the unconscious, right? Davenlu would go on and on about how the key to unlocking the unconscious is for the patient to experience the complex transference feelings, right, in the T. All right, and I mentioned the objective countertransference here. So moving right along. So Q4 now we're back to this realm, right? Psychodiagnostic considerations. All things related to capacity and mobilization. So here we're very, very focused on the pathways of unconscious anxiety discharge. We're focused on types of defenses, thresholds, levels of ego syntonicity versus dystonicity. We're looking at self functions, what are their object relations abilities, self-observing capacities, etc. This is where we are primarily focused on unconscious signals, messages from the unconscious, and of course the UTA, the unconscious will to get better, to be free and healthy. So these are the four quadrants. Quadrants, I said that funny. Quadrants. Now, on to another slide. So check this out. Same quadrants, okay? But now, right, see this little blue arrow? Tier 1, okay? Tier 1 mean all aspects of the clinical work not related to major mobilization of the unconscious and the patient's psychodynamics. So, meaning, inquiry, dynamic inquiry, phenomenological inquiry. We're looking at establishing rapport. We're looking at clarification of defenses and resistance, establishing the conscious alliance, assessing the self functions and the ego adaptive capacity to an extent, getting to know the patient, and minor mobilization, not major, nothing like really ramping up towards an unremitting standard approach, vertical, but minor. Even in tier 1, we do need some mobilization, right? Or it's just, it's completely flat. So minor mobilization, getting to know the patient, inquiry, yada, yada, all tier 1. So what I mean to highlight here with this graph, now we have the same quadrants, but look here. The proportionality is the key. So here, Q1 and Q2 should take up most of your attention, right? When you are the therapist and you are in tier 1, you shouldn't be all that focused on Q4, or Q3. A little bit, sure, always, but not massively, okay? So, for example, a very common mistake that I see is that before there's a robust buy-in and a conscious therapeutic alliance, some therapists are so eager. So they're like the whole attention, the whole focus is on Q4, which has to do with the pathways of the anxiety channels and the defenses and maintaining a rise and trying to get a breakthrough and unlocking, what is the unconscious saying and all of that. And that's wonderful when you're in tier 2. But if you get into that, when you are in tier 1, mistakes can happen. You can get misalliances. And so, for example, take the patient who is coming in because all of their relationships keep falling apart, and the therapist is hyper focused on the micro experiences of what the patient is sensing, what their sensations are in their stomach or their shoulders or their neck or whatever. And so it can lead to a situation where the patient will rightly feel, I'm not really here for the sensations in my stomach. I'm here because all of the relationships in my life keep falling apart. And so that can create a misattunement and a misalliance. Obviously, you can still work on sensations and all of that stuff as long as you really make it clear to the patient how that relates to their priorities for treatment. But my overall point is that a common problem is that Q4 takes up the entire radar screen when it shouldn't. It's a common mistake. All right. So having said that, let's get back to this picture here. So tier 1, right? We're going to be concerned about the conscious alliance, all things related to the conscious will here, Q1. We're going to be concerned about Q2, okay? All things related to the real relationship, establishing rapport, right? Can the patient differentiate the therapist from past figures, right? We need to make sure that there's a real foundation to go deeper. Okay, moving right along. to this little picture right here. Now, see that we are in tier 2. So this means major mobilization towards breakthroughs and unlockings of the unconscious. And we're talking standard unremitting vertical technique. Vertical because it's straight down right into the unconscious. Now things are flipped around, aren't they? So the proportionality is all different. So here, Q1 and Q2 should have a very little space on the radar screen, but what should take up the bulk of the therapist's attention are all things related to capacity, mobilization. Here's where we need to be hyper-focused, right, on thresholds and maintaining a rise, increasing the rise, and all of that kind of stuff. And we need to be very focused on all things related to the transference. Right, allowing the therapist to be the safer object where transferential conflictual material can be addressed and worked through. This is where we listen for the whispers of the unconscious and so on and so forth. Okay, so I hope that is clear. Now let me go back to the first picture here, sort of just the bird's eye view. Okay. So I mentioned that a very common problem is that therapists get honed in right over here in Q4 very early on, so eager to get the dramatic fireworks and breakthroughs, and because they can be so healing. So I can't blame the therapist, myself included, when I get into that mode. But anyway, I mentioned how that can be problematic. And let me do a little spin around and go through all the quadrants here and mention what could be problematic with the others. So Q1, all things related to will. The common problem here is either getting ahead or not realizing that there is will, but you act as if you don't have the will, and then you're just meandering and flattening out the process when you actually have some engagement. So, right, Q1, the common problem is moving ahead as if you have will online when you don't, right? That tends to go wrong in Q1. Or you don't recognize that you do have enough will and buy-in, but so you just stay there and actually impede the process. So those would be the common difficulties with Q1. Q2, common difficulties. So that would be a matter of balance. All things real relationship, non-transferential component. So this would be if you are overly self-disclosing, or you make it about your own needs. Like, oh, I need you to have an unlocking so I can feel good about myself as an ISTDP therapist, right? That's like atrocious. You don't want to ever do that because it's not about you. It's about them. They're not paying you for you to get your own needs met, right? So we all know that. But so that would be problematic here in Q2 if you fail to strike the balance between being a real human being, but also remaining professional and really making it clear that we're here for the patient and their therapeutic needs for them to reach their goals. Now, difficulties related to Q3, all things transference. This would be if we're going for feelings towards us in the transference, but the patient does not have clear differentiation. They don't have a solid footing here in the real relationship. And so they lose differentiation and cannot distinguish you, the person of the therapist, from the people from their past that may have been wounding. And so proceeding with exploring feelings towards the therapist when that distinction really isn't in place, maybe you have stepped in the shoes or something like that, that can be highly problematic here. Also, if you are having a reaction and you're thinking that it's an objective countertransference, meaning a diagnostic tool giving you a window into what's really going on for the patient, you can run into problems of assuming that it's objective when really it's subjective. It's really a response to your own idiosyncratic, unresolved stuff, but you're thinking this is objective countertransference. So that's fairly common. And I mentioned already, right, the problems with Q4. Now, if you are in tier 2 and it's time to really go for it, then If you are lingering and maybe trying to create a corrective emotional experience or what have you, then that could also be quite problematic because what is needed is this acute laser focus on mobilizing the patient and getting the rise and maintaining the rise and so on and so forth. So there you have it. That was the quick and dirty overview of the ISTDP perspective and proportionality quadrants, the PP quadrants for short. I hope that was helpful. Thanks for watching. Until next time, bye-bye.